Welcome to AETCM, the emergency medicine channel. Today let us discuss about antihypertensive medications. Before that, we should know what is systemic hypertension or high blood pressure. Normal blood pressure may be less than 120, less than 80 millimeter of mercury. Even 120/80 also can be taken as normal. Elevated BP means systolic BP 120 to 129 or more than that. Even if it is very high, we can call it as elevated BP only. But 120 to 129 in most of the patients will be taken as mildly elevated BP. And diastolic BP, if only systolic BP is elevated, we call it as systolic hypertension. Sometimes even diastolic BP also can be elevated. Then it can be diastolic hypertension. In some patients, both systolic and diastolic BP will be elevated. Whatever it is, less than 120, less than 80 is normal. More than that is abnormal, and that can be called as systemic hypertension. And again, it is classified into stage 1, stage 2 and other types of hypertension that we will see afterwards. And basically, systemic hypertension is divided in two major categories. One is primary or essential hypertension without any major secondary cause. 80 to 90% of the causes are due to this primary or essential hypertension. Secondary hypertension means there is a reason for that, especially endocrine reason, renal disorder, neurological disorder, whatever it is. There is a reason for elevation in the BP, that is secondary hypertension. First of all, we see the categories of hypertension. So BP normal is less than 120, less than 80, diastolic is less than 80, systolic less than 120. Elevated means 120 to 129, and most of the time diastolic BP will be normal in that condition. But whereas in stage 1 it is systolic 130 to 139, diastolic 80 to 89. Stage 2 is 140 or higher in systolic, 90 or higher in diastolic. And crisis means higher than 180 and higher than 120 is hypertensive crisis. Now you can see here why we are worrying about hypertension. That is because of the end organ damage. Any patient who is having long-standing hypertension, they can have end organ damage. End organ damage means patient can have renal disease, patient can have heart disease, patient can have retinopathy, patient can have stroke. Various vascular disorders are associated with hypertension and diabetes. So depending on the stage and grade of BP, you can have various organs can be involved. This chart explains you that various involvement of other organs, and the categorization is given like this by various organizations. Whatever it is, depending on the stage of the hypertension and grade of the BP, patient can have low risk, moderate risk, high risk or high to very high risk categories. When we treat a patient with hypertension, we have to take certain histories. That is very important. One is duration of hypertension. If the BP starts from a younger age group, then there is a possibility of secondary hypertension in that patient. If the BP starts around 40 to 50 years or 50 to 60 years, mostly it is a primary or essential hypertension. But again, if the BP starts at an elderly individual suddenly without any reason, there also you have to suspect secondary causes, especially like renal artery stenosis and all, or renal atherosclerotic disorder. Then previous history of treatment, previous treatment history is very important, because some patients might have taken treatment during the younger age, especially in pregnancy time they might have taken treatment. That is very important. Then family history of hypertension and cardiovascular disorder, both are important, because we have to stratify the risk in this type of patients. So family history of hypertension, family history of atherosclerotic or heart disease is very important. Dietary habits are very important, because we should know what type of diet is patient is taking, whether high salt diet, high carbohydrate diet, or high fatty diet. All these things are very important. Psychological stress analysis is very important. Other risk factors are like overweight, cholesterol levels, history of smoking, diabetes, physical activity, alcohol. All these things are important. Now, high sodium in the diet is very, very important for some types of hypertension. We should remember that all hypertensions are not salt responsive. Some patients' hypertension is depending on the salt intake. Some patients, the hypertension does not depend on the salt intake. So, in a patient who is having dependency on salt, if you control the salt, then BP can be easily reduced. So, whatever it is, salt intake should be restricted in patients with hypertension, fluid overload, cardiac failure, peripheral edema. All these type of patients, salt intake should be restricted. Extra salt should not be taken by these patients. But if there is a renal failure, there should be complete control of salt intake. Now, evidence of secondary hypertension should be ruled out in very young patients who is having hypertension, like history of kidney disease, physical appearance changes, muscle weakness, sweating, palpitation, tremors. All these things are pheochromocytoma features. Breathlessness, that indicates cardiac failure, sleep disorder, obstructive sleep apnea syndrome, snoring, daytime somnolence, hypothyroidism symptoms, and drugs which can elevate BP like phenylephrine, pseudoephedrine, amphetamine. All these things should be taken. Steroids, another important cause is steroids, NSAIDs. All these things can increase the BP. Target organ damage analysis should be taken, like history of TIA, history of stroke, transient blindness, chest pain, myocardial infarction, breathlessness, like LV failure, sexual dysfunction. All these things are very important. Other comorbidities like diabetes, heart disease, neurological problems, anemia, connective tissue disorders, cancer, all should be ruled out. All conditions where hyperdynamic circulation occur, like anemia, thyrotoxicosis, pregnancy, all these conditions, you can see systolic BP will be unusually high. That doesn't mean that patient is having hypertension. That is all because of the hyperdynamic circulation. So, we have to take a detailed history of all these comorbid conditions. Diabetes, because most of these diabetic patients can have associated hypertension, and many of these patients can have severe postural hypotension also. So, we have to keep that in mind to treat the patient. So, a diabetic patient who is having high BP, always check the postural BP, because most of the patients can have postural hypotension. So, on standing, BP may drop down drastically. So, when we start an antihypertensive, there is a chance of sudden collapse of vascular compartment, and patient may develop hypotension, and patient can develop fall. Now, there are a lot of causes for secondary hypertension. In that, most important is renal disease, either renal failure like parenchymal renal disease like glomerular nephritis, SLE, diabetes, polycystic kidney disease, renal tumors, all these things. But elderly individuals, renal vascular disease also common, because atherosclerotic renal vascular occlusion can occur in patients who is having chronic high cholesterol, chronic atherosclerotic diseases they can have. Endocrine diseases like Cushing's, pheochromocytoma, acromegaly, Conn syndrome, thyrotoxicosis, hypothyroidism, adrenal hyperplasia, Liddle syndrome. So many conditions can produce secondary hypertension. Drugs like steroids, oral contraceptive pills, anabolic steroids, NSAIDs, amphetamine, all these things can increase the BP. Aortic defects like coarctation of aorta, aorta arteritis can falsely elevate BP on one side of the body or one side of the arm, it can be elevated. Obesity, metabolic syndrome, obstructive sleep apnea, pregnancy, eclampsia, alcoholism, all can increase the BP. So, detailed history and detailed evaluation is most important before starting any treatment. Now, target organ damage. When we are discussing about target organ damage, three important target organs are we have to evaluate. One is kidney, other one is heart, third one is brain. Kidney patient can have nephrotic syndrome, chronic kidney disease, and end-stage renal disease. Heart, coronary artery disease, myocardial infarction, congestive heart failure, ventricular tachycardia, or any types of arrhythmias are common. Brain, stroke or TIAs are common. Transient blindness also can occur in patients who is having hypertension. So these are the common end organs which can get damaged in hypertensive disease. Now, when we are evaluating a case of hypertension, we have to examine the patient. Most common symptoms are hypertension is a silent killer. We all know that. So there may not be any symptoms in the patient. Maybe they can have mild headache, fatigue, and palpitation. That is a most common finding. Otherwise, most of these patients will not have any symptoms. If there is associated cardiac failure, breathlessness, palpitation, all these things can be there. Now, signs: high systolic or diastolic BP, heaving apical impulse due to left ventricular hypertrophy. Loud A2 is a very classical finding in chronic hypertension. Ejection systolic murmur in the aortic area can be there. Optic fundus can produce hypertensive retinopathy. Pedal edema can be there in many patients. Secondary hypertension patient can have renal bruit in renal artery stenosis. Radiofemoral delay in coarctation of aorta. Postural hypotension is very classical in diabetic patients and autonomic dysfunction. So we have to be very careful in patients who is having diabetes with hypertension. Postural BP has to be examined. Now, lab investigation, some routine lab investigations we have to do: blood sugar, serum creatinine, sodium, potassium, calcium, lipid profile, thyroid function test, hemoglobin, uric acid, urine routine, ECG. So these are the basic investigation, and some other set of investigation can be done in patients who is having suspected secondary hypertension. But primary hypertension, we don't do much investigation. We just do some basic investigation like sugar, cholesterol, electrolytes, and ECG. Now, once you diagnose hypertension, repeated readings are always required to make a proper diagnosis. 1 or 2 readings may not be enough. At least 3 months we have to watch the patient. If there is no target organ damage, at least 3 months we have to watch the patient. Repeatedly check the BP, and if we have doubt, take an ECG. Most of the patients who is having hypertension which is not getting controlled with a routine diet or exercise or drugs, you can get LVH. But some patients on clinic, when we examine the BP, we can see falsely it will be elevated, and if you continuously record the BP with a BP monitoring machine, you can see that when the patient is relaxed, BP is normal. So this is called as white coat syndrome. Whenever somebody is examining the BP of a patient, you can see the BP is falsely elevated, but actually that patient does not have BP. So we have to see the readings 1 or 2 times in clinic itself, so that we can make a diagnosis. Like that, 3-4 visits they have to do to confirm the hypertension. Once you confirm the hypertension, then we can go for lifestyle modification. That can be done by weight reduction. You can reduce some amount of BP. DASH type of diet, that is dietary approach in systemic hypertension. You have to advise the patient to take more fruits, vegetables, that increases the serum potassium level in the body, and it also relaxes the blood vessels. Low fatty and dairy products, that should be reduced. Then salt should be reduced to 6 grams per day. But if the patient is having renal failure or cardiac failure, then you have to restrict the salt to 2 grams per day. Exercise, regular aerobic exercise for 30 minutes, that is brisk walking, is a must for all patients who is having hypertension. Alcohol should be restricted. A minimal amount of alcohol can dilate the blood vessels, but if the patient is unable to control the limit, then that itself can increase the BP. Smoking should be stopped. This is the lifestyle modification strategy in hypertensive management. Now, when we are treating a patient with, when we decide to treat a patient with hypertension, we have to start drugs like AC inhibitors, ARB, calcium channel blockers, diuretics. The previous strategy was ABCD strategy, that is AC inhibitors or ARB, beta blocker, calcium channel blocker, diuretics. Any of these drugs can you select from this group ABCD, any drug can be selected. But current strategies remove that B. B is beta blocker. Beta blocker is no longer a first line drug in treatment of antihypertensive. So that is removed, but it can be used in some compelling indication that will come afterwards. So you can start either AC inhibitor or angiotensin receptor blocker or calcium channel blocker or diuretic as a first line therapy. If that drug is not working, then you can either increase the dose or add another drug. The problem with antihypertensives is whenever we start a drug, to get the optimum result of that dose, we have to wait at least 2 weeks. So suppose we are starting one AC inhibitor now, like 2.5 milligram enalapril. We have to wait at least 2 weeks to recheck the BP to see whether that medicine has got its optimum effect and BP is controlled or not. Then only we should either increase the dose of the same drug or add another drug. In between, never try to check the BP or try to adjust the BP if there is no compelling indication for that. Compelling indication means somebody is having very high BP with cardiac failure. We have to reduce the BP very fast. Otherwise, we need to give time for the patient. They have to do regular exercise, salt restriction, stop alcohol, stop smoking, then start this treatment and wait for 2 weeks, review back in the clinic and see the BP. If BP is getting controlled, then that tablet is enough. So this will be the chart how to start drugs. We have to start either a thiazide diuretics, AC inhibitor or ARB or calcium channel blocker. Beta blockers are not first line choice in any treatment. But remember, patient who is having diabetes, that is the most common associated condition with hypertension. If the patient is having diabetes and diabetic nephropathy, proteinuria, AC inhibitors, ARBs are the better choice than other two drugs. So we can start AC inhibitors or ARB in a patient who is having proteinuria. That will be the first choice. If due to any reason we are not able to give that drug, then calcium channel blocker will be the second choice. If the patient is having very mild BP, then always diuretic will be the choice of the drug. And when you are starting diuretic, you know that there is a chance of losing potassium from the body. If there is already an hypokalemia existing in the patient, don't start diuretic, that's all. Otherwise, diuretics are always the first line treatment in most of the simple essential hypertension patients. First line basic treatment, you can start any diuretic and wait for 2 weeks. If the patient improves, continue that treatment. If the patient does not improve, either increase the dose or add another drug like AC inhibitors or ARBs. We have AC inhibitor ARB combination with diuretics, that also can be added. Now you can see here there are some indications for each class of drugs. So initially what we have seen is we have to start A, C, D, that is a group. B is removed from the first line therapy, that is beta blockers are removed. But here what we are telling is what are the indications for each class of drugs. Thiazides, you can start for isolated systolic hypertension, cardiac failure, elderly individual, secondary stroke prevention, all these things we can start thiazide. Beta blockers, if the patient is already having a myocardial infarction, angina, heart failure, tachycardia, then beta blockers are the choice of drugs. Alpha blockers, if the patient is already having benign prostatic hypertrophy or prostatism, this may be the first line drug. But most of the time alpha blockers are second line drug in treating the hypertension. AC inhibitors or ARBs can be started in all types of patients, but it is not used in patients who is having renal failure and pregnancy. So we have to remember two important contraindication for AC or ARB, that is renal failure, other one is pregnancy. We should not use it. Other all condition these are the drugs of choice, and they are very useful drugs in left ventricular failure, post-myocardial infarction, coronary artery disease, diabetic nephropathy, proteinuria, stroke prevention. All these things, these are the drugs of choice. And if due to any reason you are not able to give ACE inhibitor or ARB, calcium channel blocker is the next choice, especially in elderly individuals. Isolated systolic hypertension, this is the drug of choice. Calcium channel blockers are the drugs of choice. So there are some difference between two different types of calcium channel blockers: nifedipine, amlodipine, one group; diltiazem, another group. Nifedipine, amlodipine increases the heart rate, whereas diltiazem, you know that it decreases the heart rate. So when there is a tachycardia or supraventricular tachycardia or any other arrhythmia, diltiazem will be a choice of drug. But if there is no other problem, you can give nifedipine or amlodipine. Now diuretics, we have different types of diuretics like thiazide, like hydrochlorothiazide, loop diuretic like furosemide, potassium sparing diuretic like spironolactone, eplerenone. Only problem with spironolactone is it can produce some gynecomastia. That's why other drug has come, like eplerenone is a drug which is a potassium sparing diuretic. At the same time, it will not produce gynecomastia. So we should know the common side effects of these drugs. The most important side effect will be patient can lose some water and patient can lose salt. So hyponatremia and hypovolemia can be a major side effect for all these drugs, but in smaller doses this is not a problem. So this can be used as a first line drug in most of the hypertensive patients, including patients who is having cardiac failure and all. We can use this. Potassium sparing diuretics should be used only if there is hypokalemia, or for ventricular remodeling also we can start. Otherwise, normally we give thiazide diuretics like hydrochlorothiazide can be started as an initial drug, 12.5 to 25 milligrams. So any patient who is having hypertension, who is not having any major end organ damage, we can start hydrochlorothiazide. Next drug is beta blocker. Beta blocker, we have atenolol, bisoprolol, metoprolol, propranolol. In that, atenolol and bisoprolol are the commonly used drugs for hypertensive control. Metoprolol IV is also available, so it is mainly used in arrhythmia control and other problems in emergency room. But the tablets are also available. We can even give metoprolol tablet. Carvedilol is nebivolol and carvedilol are newer drugs that can be safely given in asthmatic patients also. So these drugs doses are given here, but the most important use of beta blocker is hypertension with heart disease, hypertension with tachycardia, hypertension with ischemic heart disease, hypertension with myocardial infarction. Beta blockers are the best choice. Next drug is angiotensin-converting enzyme. We have captopril, enalapril, ramipril, lisinopril, like that. So many tablets are there. They can be used in systemic hypertension, simple hypertension, cardiac failure with myocardial infarction, diabetic nephropathy. Anybody is having proteinuria, these are the first line drugs. But only problem is if creatinine is more than 3 milligram per deciliter, don't try to use this drug. Renal artery stenosis, avoid this drug. Aortic stenosis, avoid this drug. HOCM should be avoided. Carotid artery stenosis and pregnancy, this drug should be avoided. Some drugs like AC, some major side effects like dry cough can be there in many patients who is on angiotensin converting enzyme. For them we can give either ARB or some other antihypertensives. Angiotensin receptor blockers like losartan, candesartan, valsartan, irbesartan, telmisartan, all are available. The usages are same as AC inhibitors. Dry cough incidence is very less in ARB. It is not at all there. So if any compelling indication is there, you are not able to use AC inhibitors, you can go for angiotensin receptor blockers, and they are also contraindicated in same manner like AC inhibitors including pregnancy. Calcium channel blockers, there are two important types of calcium channel blocker. One is rate limiting calcium channel blocker like diltiazem and verapamil. Other one is antihypertensive, but it will not do anything with the rate and rather it may increase the rate, like amlodipine, nifedipine can increase the heart rate. Amlodipine and nifedipine are very good choice in controlling the BP, and it also improves the coronary circulation, whereas diltiazem, verapamil, it controls the BP, it also controls the heart rate, it also improves the coronary circulation. So the uses are slightly different. Whatever it is, calcium channel blockers are the one of the first line therapies in hypertensive therapy, and any patient who is having elderly and isolated systolic hypertension, calcium channel blockers are the drug of choice. So an elderly individual who is having systolic BP of 180 or 190, diastolic BP is normal, amlodipine or nifedipine will be a better choice. A patient who is having tachycardia and high BP, like supraventricular tachycardia with high BP, diltiazem may be a good choice. So depending on the clinical scenario, slightly different approach has to be taken. Since they are calcium channel blockers, they can even aggravate the cardiac failure. So we have to remember that if a patient is having cardiac failure, suddenly if you introduce calcium channel blockers, that may increase. So we have to be very careful. Beta blockers and rate limiting calcium channel blockers together should not be given in any patient. Like if the patient is already on a beta blocker, suddenly if you are introducing diltiazem to that patient, there can be a severe bradycardia. Instead of that, we can go for amlodipine or nifedipine. That's why most of the drug combinations are like this, one beta blocker and one amlodipine or nifedipine. So the most commonly available brands are amlodipine with atenolol. So amlodipine increases heart rate but reduces BP. Atenolol decreases the heart rate but reduces the BP. So together these two drugs can have good effect on BP, and heart rate will not be changed. Alpha blockers like prazosin, doxazosin, they are very good, terazosin, they are very good drugs to control the BP, especially in patients who is having minimal response to primary drugs. So they are secondary drugs in antihypertensive management. A patient who is having benign prostatic hypertension is a very good drug, and patients who is having pheochromocytoma, also this is a first line drug. Centrally acting drugs like clonidine, this is a main drug used in uncontrolled hypertension. This may be used as a third line drug, like after starting first line drug, then try second line drug. This may be a third line drug. The dose may be 50 to 150 microgram 3 times daily. So these drugs can produce severe hypotension. So we have to be very careful. Initial management of hypertension with these drugs are not recommended. Only after first line and second line fails, we can add this drug to the regime. Most of these patients who is on clonidine can have drowsiness and lethargy or depression. All these things are major side effect of centrally acting antihypertensive drugs. Other drugs like hydralazine, sodium nitroprusside, reserpine, all are available. In that we have to remember one important drug, that is hydralazine. Previously injection hydralazine was available in our country, but at present it is not available. They are both arterial and venous venodilators, so they give very good result in emergency room controlling the BP. So we can use either injection hydralazine or oral hydralazine in patients who is having high BP, especially in emergency room. It also can be continued. Sodium nitroprusside is an infusion like NTG. It also can be given in high BP patient who is having high BP in emergency room. That can be given as an infusion. Now, there are a lot of advantages and disadvantages for various drugs like diuretics can sometimes produce problems in diabetic patients. Gout can be increased in diuretic. Cholesterol levels can be increased in drugs like beta blocker, but they are all the adverse effects are all actually negligible when we are treating a patient who is having hypertension, because the effect of the hypertension we have to see. We know that it's a silent killer. So if we don't control the BP, the target organs can be damaged. The effect of or side effect of these drugs are very, very minimal, and if we know the side effects, we can easily tackle the issue. So we have to select the drugs depending on the clinical scenario, and we have to select the drug depending on the adverse effects. So if you are doing properly, if you are treating properly, we can avoid side effect, we can have a better control in hypertension. So we have discussed about various antihypertensive, but we have not discussed about how to treat the patient, how to control the patient's BP, what are the targets in various conditions. That we have not discussed. In another class we can discuss all these things. Now we have only discussed about the major antihypertensives and their indications and contraindications and usual doses. That's all. Thank you.